Hold on a second. Okay, so good morning, everyone. I hope everyone's enjoyed the morning session so far. It's been fantastic. And I'm looking forward to the next session on clinical care. So it is my great pleasure to introduce Dr. Abdullah Saleh, who will be speaking on presenting his talk, Beyond the Knife, Global Surgery, Innovation, and Entrepreneurship. Dr. Saleh is an assistant professor in the Department of Surgery in the Division of Pediatric Surgery in the Faculty of Medicine and Dentistry at the University of Alberta. He's an alumni of the University of Calgary, who currently works as a pediatric surgeon at the Stollery Children's Hospital, University Hospital in Edmonton. He established the Office of Global Surgery, which develops global partnerships to improve access to surgical care and trains clinicians and global health innovators. Dr. Saleh also co-founded and directs Innovative Canadians for Change, a not-for-profit social enterprise which raises funds for international development initiatives. Other projects that he's been involved with include providing vocational training and access to high-efficiency stoves to refugees on the Burma-Thai border, and the Kenya Ceramic Project, a water filtration initiative that provides clean drinking water for approximately 100,000 Kenyans. Very impressive indeed. And Dr. Saleh, if you're able to share your slides, I'm very much looking forward to your talk.
Thank you so much, Joel. Can you hear me?
Yes.
Perfect. And can you see my slides?
Yes.
Awesome. Thank you so much. Okay. Well, good morning, everybody. Thanks so much for having me. So as Joel said, I'm Abdullah. I'm one of the surgeons here, and have a few slides, but I'll try to keep it pretty non-academic and as many pictures as possible because I'm a surgeon and we don't like big words. So, you know, we all wear a lot of different hats as academics, as doctors, as scientists, as people who are involved in global health or in entrepreneurship or innovation. And I want to talk about some of them today, and I'm going to try to just tell you a little bit of an unusual story about how I think we can make large-scale impact without necessarily going through the conventional way that people think of surgeons providing clinical care in a global health context. So it wouldn't be a medical talk without a case, but I'm going to use this case because I think it highlights a few issues for me. So this is I put up a CT scan, and I know not everybody might be clinical on this, but I think it's worthwhile just realizing this kind of the context of this case. So it was a 16-month-old girl who was found to have a large mass in her abdomen extending all the way up to her heart, and it was enveloping all her big blood vessels like the aorta and all the different tributaries from that. And she was wasting away because this particular type of mass was giving her something called a paraneoplastic syndrome, causing her to have so much diarrhea, intractable diarrhea, that we just couldn't keep up with her hydration, couldn't keep up with her nutrition. She was being managed as aggressively as possible medically, and we couldn't keep up. And so she was wasting away, and we were worried that she was going to die. And when you look at the CT scan, and I'll put it up right now. So this is just like starting from the back, and this is her spine, her ribs. You can start to see that this whole mass here should not be there. This whole thing is a tumor. It's ganglioneuroblastoma. And it's very unusual that they're aggressive like that in terms of secreting that type of hormone, but you can see that it's wrapped around everything. And I didn't put up the MRI on this, but it was also invading into her spinal canal. And so when you look at a case like this, you know, yeah, it's very tragic. It's very difficult. She had seen 3 surgeons, and everybody felt that it was not resectable, just given how aggressive this thing is. But so many things had to have gone right for her to even be seen by a surgeon. She had a very difficult social situation, lived with her grandmother because her mother was an IV drug user. She was lost to follow-up multiple times, but eventually she did make it to the hospital and did receive care, and we were able to get all this imaging, and we were able to see her in a hospital setting and get a biopsy and work her up. The good news is that we managed to go in, and I managed to do a combined case with the neurosurgeons, and we removed the tumor from her back on one day and then kept her asleep. And the next day flipped her over and I did her belly portion and managed to remove everything all the way from her heart, all the way all around the vessels. And miraculously, she not only survived the operation and didn't have any injuries to any of the structures, but she stopped having diarrhea the next day. And the best phone call I think I've ever received so far as staff is when they called me from the ward saying that she's constipated and if I can give her a suppository. So there's few things that really hit home as a general surgeon more than that. So, but I think that brings into idea like the whole discussion of global surgery. Like we're very fortunate to be in Canada, and this case in the rest of the world would not be handled like this. This girl would have gone on to pass away, and that unfortunately is the reality across a lot of the world. There's also a lack of, I think, realization of the scope of the impact of surgical diseases. And so you can see that as communicable diseases have come down over the past number of years, over the past couple of decades, the rise of non-communicable diseases has made this classic X. And so the non-communicable diseases, which includes cardiovascular disease, cancer, diabetes, and other illnesses, are becoming like 70, 80% of the burden of disease and mortality. And surgery is a big, big part of that. So, but surgery is definitely not being handled or being funded in the same way as some of the other global health agenda items. This is another way of demonstrating it. You can see another facet, which was not included in the last slide, is the injury and the rise of injury over the next few years to the next decade. By 2030, it makes up a huge majority of the burden of disease. But also the cancer burden is going up. And we're not exactly sure we understand why it's going up so much. Is it a function of just longevity? Or is it a function of the environmental impacts that we have? Or is it a function of infectious diseases causing cancers, like in cervical cancer with HPV and other types of viruses causing cancers? Now, those of you who are involved in global health and global surgery, I'm sure have seen this. This is the Lancet report for global surgery, and the Lancet had put a commission together to really promote global surgery in this field of trying to improve surgical access for the most vulnerable. This is a proportion of the population around the world that does not have access to surgery. And I can give all the like typical stats that 5 billion people don't have access to surgery, that we need 165 million surgeries a year just to keep up with the current burden of surgical disease. But you can see that disproportionately Africa and Asia, and particularly South Asia and Southeast Asia, are disproportionately represented on this map. And I want you to also keep an eye on Russia and China and look at that, that there is a significant proportion of the population that does not have access to surgical care. Now, when it comes to surgical care, surgery is expensive. It's an infrastructure heavy field, but the truth is that surgery is actually as cost effective, if not more cost effective than even vaccinations, because your burden of disease and your burden of disabilities is so high over so many years that if you intervene early, you can have very productive members of society. But unfortunately, the funding agenda does not reflect that. So if you look at the Global Fund, which primarily focuses on HIV/AIDS, there's about $4 billion annually. Injury in terms of trauma and people getting injured from accidents and workplace injuries and intentional harm and violence does not have a fund like that. And total surgical burden of disease does not have a fund like that. And there's now efforts to try to get some funding and some money committed to that. But if we recognize that 30% of the global burden of disease is caused by conditions that are treated by surgery or require direct care of surgeons, then you can see that there's a big mismatch. I'm happy to report that like now there is way more of an appetite for global surgery. But that at the same time, just because there's a big appetite doesn't mean that we're going to have sustainable interventions. Doesn't mean that the things that we think of when we are like, oh, we need more surgery, we need more surgery. Well, what does that actually look like? And what are the risks of harm? And how do we make scalable, positive impacts around the world without contributing to the same errors that I think the global health agenda has faced with other diseases like malaria and HIV and even some of the other conditions. Let's look at surgeon density. And the reason why I wanted you guys earlier to focus on Russia and particularly Russia, you can see there's a lot of surgeons in Russia, but the population that lacks surgical access is still very limited, because it's not just how many surgeons you have in your country, which is what this map shows, but it also depends on your urban, rural, your private system versus public system, and who's actually accessing this. And that's one of the pitfalls, or one of the challenges with the Lancet, that it still very much aggregates big numbers, and it's hard to draw real conclusions or actionable items from that. For me, whenever I talk about the fact that I'm a surgeon and I work overseas, everybody thinks that this is what I do. People are like, oh, you go overseas and operate on little children. And I'm like, well, this is probably what they imagine, that I go and do cleft lips and palates in the rest of the world, and it's very admirable, and I can post about it and all that. The truth is, I don't do that. I don't do surgery overseas. I don't do clinical work, and it seems like a weird thing to for most people, of why I wouldn't use the skills that I spent a million years, what feels like a million years, getting trained to, and not do those in a setting that needs it. But it's because I'm constantly concerned that the risk of harm and the inadequacy of just providing pure clinical care without a bigger picture or a bigger system level view of where we're going will lead to, inadvertently, to harm and to problems. And more importantly, it will lead to a lot of time being spent on maybe the wrong beneficiaries. What I mean by that is that it's very attractive, especially now that global surgery has become a very popular thing, for people to pack their bags, go and do 2 weeks in Honduras or in India or wherever, and then I can do 100 cases and feel great about it and take nice photos like this, and then I can tack on a week vacation somewhere and then come back home. But the truth of surgery and the risk of direct harm, if you're operating on someone and I have to leave, and if I'm doing particularly complex cases and leave with no follow-up, or even the environmental cost of me flying over there or flying with the team, when they have surgeons there. So why am I going and operating? And I know that that's a controversial point, and I'm happy to entertain questions on that, but it's something that I felt was important enough for me to focus my time and energy on different things. And I'll talk a little bit about those. As far as my role in terms of doing global surgery in a clinical setting, I've taught overseas, I've given advice, I've facilitated fellowships, and we helped build the Office of Global Surgery. And one of the big things that we worked on was looking at how can we have a more mature conversation around the ethical pitfalls of surgery, because it has to address the real inequities and the real power dynamic, that if I'm a high-income university, or a university in a high-income setting, and wanting to go to an African hospital, then yeah, they might want us to come because there's a lot of benefits. There's political benefits, there is like real tangible benefits, but there's also a very real power differential there, where I can go there and not necessarily be fully licensed and do cases that you would never let somebody from Zambia come here and operate on your kids. You'd never let your kid have their picture taken like that and post it on the internet. So why do we do that to these people? And that became a real issue. And I think it's a very hard thing to talk about, because it's done with the best intention. So how do we address it in a way that enables the people who are maybe vulnerable and in a disadvantageous power dynamic to be able to have language and tools and stuff to discuss that. So we looked at developing, this is like a multi-year initiative, but we looked at developing domains that we can talk about the ethical pitfalls, and so, those are 6 of them that we focused on, but it's really looking at clinical care and delivery, education, and certification, research, and monitoring and evaluation, environment in terms of environmental impact of everything that we do as surgeons, but also the healthcare system and the travel and all that of doing back and forth short-term surgical missions and mercy ships and all those things that happens. And what about donated equipment and these graveyards of ventilators and dialysis machines and everything that exists in the rest of the world? What about the economic impact of bringing all our own supplies there and then taking them back? And what does that do to the economy there, or to the hospital's dynamics when we interrupt their flow as a hospital and do 2 weeks of orthopedic surgery or a sprint of hernias in a pediatric surgical camp or something like that? What are the real economic challenges and for the families and to the hospital? And then really the last domain, which I think is one of the most critical and most foundational, is how do we handle engagements, collaborations, partnerships? How are we doing that ethically? We'll think about, when we talk about ethics, people are like, oh, did you get informed consent? Sure, informed consent is one part of it, but that's a doctor-patient relationship. But there is business ethics and there's relational ethics about looking at how do we work with people and partners and things like that. So this is a big group that we assembled together from all over the world and worked on developing an ethics in global surgery framework. And I won't spend too much time, but I'm happy to go over that with anybody. And but it forced me in my life to really think about how else can we do that instead of just surgery and operating with my hands. What else can we do? And I want to talk about two different ways that I think we can make an impact as surgeons or as clinicians or as global health practitioners or even lay people. But I think innovation is one way. And if you look at the number of surgical cases in the world are related to typhoid, is ginormous amount of operations that happen for waterborne illnesses, and water sanitation is a key part of global health. So as a med student, a group that I was involved in developed a point of use water filtration system and worked on subsequently bringing that innovation to sub-Saharan Africa, to Kenya, and built a factory. This is me in the back of some van building this machine, which ended up looking like this, and it's just a monstrosity. It looks like a low-cost transformer. And but this is what we ended up making: a ceramic water filter sitting in a receptacle for safe water storage with a tap at the bottom and a lid. And this is some of the workers, and it went on to be commercially successful and reached about 140,000 people, and we're now scaling it. But I want to point out that, like, no matter how, in 30 years of my practice that I might have, if I went 4 times a year, or even if I lived my entire life doing surgical care in those developing countries, I'd never be able to reach the impact of 140,000 people. And that is much bigger impact. And granted, it's not just like numbers that we're talking about, but I think it's types of impact. And that's what I really want to leave you guys with. It's just some of the first people that received the filter when we first made it. Another surgically relevant and important point is trauma and injury, and that's a huge burden that we talked about. So we worked on developing a systematic approach to trauma and injury from the pre-hospital system, where you had so many, like each one of those dots is a hospital. This is just 50-kilometer radius in Western Kenya, but people were being transported for 8 hours to go to one hospital, meanwhile bypassing a lot of different infrastructure because there wasn't a coordinated system. So how do we go about building this coordination? How do we go about introducing educational systems like advanced trauma life support and bringing innovations and educational platforms and interventions that can be locally sustainable and locally championed? And this ATLS program in Kenya, which is the first successful one in sub-Saharan Africa, has been running for about 4 or 5 years. And it's trained all the surgeons in Kenya, and it's now become a model for the rest of East Africa. This is us training one of the first cohorts, and this is the first group that accredited the advanced trauma life support. There's other ways that you can do that, introducing low-cost trauma hubs in at the right place by understanding the geographical incidence of trauma and where are those hotspots, and how do you come up with new and innovative ways to address the geography. I mean, Canada is a good example. If I have somebody getting injured in high level, I probably would want them to stop in Grand Prairie to be stabilized rather than flown or driven here. And that changes your outcomes. And that first golden hour is critical. So how do we build these interventions? And this is one of the projects that we did with the Red Cross. The last kind of part that I want to talk about, and I know I'm just powering through this, but it's this idea of entrepreneurship, and it's an uncomfortable thing to talk about money and talk about income generating, but I think doctors are not good at business in general, and I think if we don't look at sustainability from an economic sense, I think that this whole thing becomes a fool's errand, and if we don't put the time into building this into, it's a fine line. It's a transition from innovation to action research to entrepreneurship, and that's what I think the evolution should go, and that's what we're starting to see. But one of the definitions that I like is this, that entrepreneurship is the creative or is the creation or extraction of value. And I think the term value is very important, and value to whom is I think what it comes down to, because a lot of the time it's value to us, either academic promotion or benefits or grants or even hype or a good feeling or easing of guilt. But I think it's also has to be viewed as change, generally entailing risk beyond what is normally encountered in starting a business. So not just like, and that's what makes an entrepreneur, somebody who ventures in there and jumps in. But importantly, that value is not just economic, that's where the idea of social entrepreneurship can come, and well, a lot of the stuff that we do. This is one of the companies that we started, which is when we looked at all the trauma and injury and we were improving pre-hospital care, we had all these patients surviving the pre-hospital phase, showing up to a hospital and dying in the parking lot because we didn't have surgical instruments. So what are the bottlenecks of that? How do you bring innovations? What if you use 3D printing to make surgical instruments? This is some of the first prototypes that we were making with one of our spin-off companies. At the same time, the access to blood. If you want to successfully promote surgery, not just surgery, obstetrics and gynecology, postpartum hemorrhage is one of the biggest killers of women. And so how do you provide blood safely? How do you coordinate its donation, its storage, and its transportation and accounting? So we've been incubating one of those companies that focuses on that, called Damusasa, out of Kenya, and they've come up with a way of leveraging a mobile platform and a hospital-based platform, and working with the post office to transport blood. And this is like a cooler at the back of a motorboat, like one of those motorbikes that can transport blood, because that's what they have. That's the local innovation. That's the entrepreneurship that you can see in those places. I think ultimately it comes down, I think, to the students and to the people who are on the call who dream of these kind of moonshots that you think, to me, I always see it as like, you have that voice on the inside that's telling you that maybe you're not good enough, or people from the outside. I remember when I was starting a lot of this stuff, people will always tell you that you don't have the time. It's not your place to be doing this. You might not have the skills. You're a med student. Shut up and just do your job and be good at it and try to match into a residency. And then you can do all of that once you're done. The truth is that I don't think that's good enough. And I think it takes just the first few steps and being willing to fail. But it also, I think, takes, these kind of steps that in my mind, I kind of always think about is you need a vision, like just dream big. Don't be afraid of failing. Commit the time, because anything that's possible will take longer than you can possibly imagine, but it'd be more worthwhile. And it takes energy, but that energy is both, you put in energy to get back energy. And the last part, I think, is the most important for me. And I think sometimes the most paradoxical, because people are like, why do you work with people who don't have necessarily the most skills in the field? But I find like, if you work with good people, it doesn't have to be the best people for that particular task, but people who are aligned and have the same values and want to do the same thing and are doing it for the right reasons, will take you much further than just having that one expert that's able to tell you exactly why this will work or will not work. So, I think for me, it was always that this quote resonates, that two roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. And that, to me, has made all the difference. And the fact that I'm back here working where I wanted to work, doing the things that I love to do, and then also being able to hopefully one day make an impact. But who knows? Only time will tell. Thank you.